1 in 3 women die of heart disease, not something else. We're not talking about something that's obscure and rare.
What are the common symptoms I should be aware of as a woman?
So there's a range of things.
Women-specific risk factors.
We are not smaller males
Menopause. What is the link to heart disease?
because they are biologically changing. The risk of cardiovascular disease, particularly atherosclerosis,
Microvascular disease or menarche. Specific type of heart failure that affects women particularly. It's HFpEF, SCAT. What do women need to know?
every minute is important.
When I'm at the doctor's, I want to know what to ask.
You've got power to advocate for yourself.
Welcome to Core Magna Heart and Soul, where we dive deep into the topics that matter most to your heart, your health, and well-being. Now, here's something that most people don't know. Heart disease is the #1 killer of women, not just in Australia, but all around the world. And the scary part? Women's symptoms can often look very different to men's, and they're easy to miss. That's why this Women's Health Week, I'm sharing what everyone needs to know about the biggest health risk that women face. In this video, you'll take away the key warning signs to watch out for, the risk factors that are unique to women, and the heart conditions that affect women more than men. You'll also be taking away practical tools, whether that means protecting your own heart health or looking out for your partner, your mum, your sister, your daughter, or even a friend. So, if you want to make a difference in women's health, then this is what you need to know. So it's Women's Health Week here in Australia, and at Core Magna Heart and Soul, we really think it's important to shine a light on women's heart health. Why is this an important topic, Jodie-Ann?
Well, as you said, shining a light on it, we shouldn't have to. It should just be, because it is the #1 cause of death in women, not cancer, not breast cancer. It should be as important to women as it is to men. But I don't think there's that awareness out in the community.
Yeah, I'm really glad you highlighted, you started straight off with, the fact that heart disease is the biggest killer for women, not just in Australia, but globally.
Yes.
I've got some really scary statistics here. Well, scary but informative, right?
Scare away.
You can't do anything if you don't know about it, right?
Yeah.
So the first step is awareness. So,
Yes.
from the Heart Research Institute, for instance, we've got cardiovascular disease or heart disease is the #1 killer of Australian women, and over 500,000 of Australian women have some form of cardiovascular or heart disease. If we break it down to an everyday statistic, right? Every day, approximately 109 Australian women have an acute coronary event, such as a heart attack. What does that mean every year? Every year, 22,000 women die from cardiovascular disease or heart disease. If we look at what that means in a day, that's 60 women a day.
Yeah.
So 60 women every
Sobering
day.
thought.
A sobering thought, to put
Yeah.
it mildly. 60 women a day in Australia die from heart disease. And we know roughly that's about 20 of those deaths can be attributed to coronary heart disease. I mean, why are we not talking about this more often?
Well, I think, we've probably all seen those images of, and even on TV, right? The ER or whatever. It's the man. It's usually the middle-aged white man who suddenly kind of clutches his chest and's having a heart attack, and then just drops dead on the spot or is resuscitated or whatever. And that's the image that we tend to have of what a heart attack victim looks like. And if we're just talking about heart attacks, that is right for a proportion of people, but then also it's not. It doesn't actually canvass even the majority of men who have heart attacks, let alone the women who might present very differently. And if we're talking about heart disease, everyone's very focused on that typical heart attack or cardiac arrest picture, But actually, heart disease is much, much broader than that, and encompasses a range of things we've talked about before that doesn't fit that picture. But that's where the focus is, because that's the scary one that people see. It's the scary one where somebody suddenly loses their life. And so that's where the focus goes. But in actual fact, heart disease, apart from all the deaths, creates quite a bit of morbidity. And what I mean by that is, how it affects your day-to-day life. So whether it's heart failure or whether it's the disease that affects the arteries that causes the angina and the heart attacks, aside from the heart attacks, the angina can be quite disabling for some people. And I think there are differences for women in that side too that are quite important. So it's I guess raising the awareness that heart disease isn't one entity, that it's many different forms of problems for the heart and in terms of how the heart operates, and then understanding that those problems are not a male problem, they are an everyone problem.
Yeah.
Potentially.
Yeah. So there are a few things to unpack there. First, because generally, as a category, heart disease is often misunderstood as a narrowed down, reduced version of just heart attacks. So that's one problem. And on top, and then not realizing that there's a broad range of heart diseases which affect men and women just as much. And then the second problem to that is because that one subset of heart disease being heart attack represented in that male form, that reduces even more that understanding or that awareness that heart disease also affects women a whole lot.
Yeah.
So you talked about, different types of heart diseases. If I'm listening to this or if I'm wanting to do something about this, what are the common symptoms I should be aware of as a woman in her 40s that should signal to me it could be potentially heart disease, or at the very least, I need to go and have a chat with my doctor?
Yeah, it's a good question. I mean, so there's a range of things. And again, it depends on what kind of heart disease you are thinking about. But I think the first point is, as a person, we should be relatively in touch with ourselves. We should know ourselves. And most women are fairly in tune with their bodies. They generally know what's going on. So if something is definitely different and out of kilter, and this can apply to any disease, then you should advocate for yourself and at least go and ask a professional about it. So, if that's because you found a lump, or if that's because you started getting palpitations, or if that's because you normally can do a certain thing of exercise, but now you're finding that much harder and there's no obvious explanation to you as to why you can't do that, then advocate for yourself. Go raise that with your health practitioner and get it checked out. Because something that has changed that isn't easily explainable should be investigated and not just dismissed. It's very easy to dismiss it. I have a patient in at the moment. She's this beautiful Italian lady that I've looked after for more than 15 years. And she has severe illness, but it's been remarkably well managed by the Alfred Hospital. And she's been stable enough to remain on her therapy and out there doing her thing. But because she's so stoic, she really undermined her own situation by ignoring signals of change. So the change was that she started getting a little more fatigued. She started getting a bit more breathless. Her husband noticed she was starting to change color a little bit around the face and the lips, go a bit more blue. There weren't any massively obvious changes, but when you look back, they all pieced together. And she And he started noticing. And when he started noticing, she was like, no, I'm fine. She dismissed it. So she kind of, she's so tough, if I could put it that way. And so willing to just press on through things that she didn't see the importance of that change. And had she recognized it and done something about it earlier, she wouldn't have virtually been on death's door by the time she actually did present.
Wow. Right.
And this is a fairly common story, common enough, unfortunately. And again, we used to always say this with, especially with heart failure, I think when you're used to certain things, what I ask my patients, for example, is, not just what's happening right now, because again, you might ask them, they go, oh yeah, I'm all right, my breathing's all right, but they've been living with this for a while, then they adjust and accommodate. We adapt very well as human beings. So what I will ask as a question is, okay, before you identified yourself as sick as only in the last month, let's go back 3 months or 6 months. What were you like then? And did that differ from what you were like 12 months ago? Because, if somebody's old and frail and they're just gradually, unable to do things, you might be able to say, all right, well, that's understandable that there's this sort of gradual slide in their ability to do things. But, if you're looking at a 65-year-old who, is normally somewhat active, but maybe not very active, when you go back, there's often been signs of deterioration that they've just dismissed. But when you take a point in time and then go back a point in time, they go, oh, yeah, 6 months ago, I didn't have much trouble getting up that incline at the front of my house. But now I'm finding I have to sort of slow down. I can't keep up with my husband who used to walk alongside me. Or now I'm having to stop and take a few breaths, and I do that maybe once or twice, whereas I used to be able to get up that little incline in front of our house in one go. And it could be those kind of things. It doesn't have to be something really dramatic. So it can be fatigue, it can be drop in exercise tolerance, it could be heart palpitations. Some people come in and say, I experience this fluttering in my chest. It's like butterflies, and it comes and goes, and I'm not really sure what that is. Then sometimes I think it's just in my head, but I'm like not really sure. But it doesn't feel right. And I don't feel right, but I'm okay. I can still do things. It can be things like that. It could be, and women again can be a bit different in their presentation with problems with their blood vessels in their heart. They might get, instead of getting the chest pain here's another one, just in general. Everyone goes, oh, it's not pain. Actually, angina often isn't painful. Chest discomfort is probably a more accurate way to describe it. It could be tightness, it could be pressing feeling, or like, oh, my bra's too tight. That's a common one that women will say. I just feel like my bra's uncomfortably tight, but if I took it off, it wouldn't change the feeling in my chest. Women might not have that. They might have this more heartburny feeling more in the top of their stomach or the lower part of their chest, and they might mistake that for gastrointestinal problems or nausea. They might have a feeling through their shoulder blades at the back. They could have jaw or neck discomfort. Some, it's just like, oh, it's this shoulder, and I just thought it was my shoulder. I have a bit of arthritis.
Or I slept
I
the wrong
funny.
way. Yeah.
My arm's a bit like heavy. I had one lady, I think I told you last time, she just had wrist pain for her heart attack.
Yeah,
That's
that's I
unusual, but
remember that, and that's very interesting. So a specific question about that with wrist pain, because we don't want to then suddenly cause this panic where everyone's starting to feel
no,
wrist pain.
it's referred
But is it,
pain.
yeah, is it something, was that something that was recurrent without any
No,
other explanation?
she had it. So it was a day before she presented. She had out of the blue wrist ache,
Right.
heaviness, and
And was it
ache.
the left or the right?
In her case, it was her left.
Left, and that is also where the heart
Yeah.
is, right? Okay.
So left arm and left can be more common.
Mm-hmm.
It's not usually right-sided, but
Mm-hmm.
sometimes it's both.
Mm.
So the classic sort of thing is can be chest discomfort, shoulder discomfort. It can be right down to the elbows. It could be right down to the wrist. It could be only like lower parts. If it's a heart attack, that will be more intense, and there'll be a prescribed period of time that it goes for, and it's usually fairly durable. It's maybe an hour or more. Angina, however, tends to be something that is very exertion related. So the classic thing there is I'm fine when I walk on the flat, but when I try and climb a flight of stairs, I get this feeling like almost a bit of choking or pressure.
Like a lump starting to swell in my
Could
throat.
be that.
Right. I've heard of that.
Something like
Yes.
that, or like someone's pressing on my neck. And that's when I'm like at that peak kind of exertion of going up the stairs. But as I get to the top of the stairs and I stop, it starts easing up. That very exertional nature of that discomfort is very classic of angina. It tends to come with exertion, go with rest. And so anything that's new that is exertion related like that, that is something that we be concerned about as a heart specialist to go and investigate. And if it is exertion related, we might be able to bring that out with putting someone on a stress test or a treadmill, because again, you're replicating that level of activity that's bringing out the symptoms. And that's an important way to kind of look at that.
Yes, I think it's really important that we really emphasize the symptoms that women tend to miss. Some items that the Heart Foundation has very helpfully listed here. So again, these to me sound like very common and benign symptoms: getting sweaty all of a sudden, feeling sick, so nausea or vomiting, which could be very easily misinterpreted as a gastro issue, like food poisoning. Dizziness.
Yep.
So there are also these three that we tend to not acknowledge as heart related.
Yeah, and it's not uncommon that people come in thinking they have some sort of gastrointestinal problem, and then it turns out they have heart problems. Women in particular are not thinking, oh, this could be my heart, because they're not thinking they have heart disease anyway. And it's a shock to them when they find out that their nausea and gastrointestinal upset is actually caused by something that's happening in their heart, or the sweatiness, especially if you're a certain age, you're wondering, is this a perimenopausal thing?
Breaking out into sweat, particularly I think if you're not exercising and it's not related to a prior activity, and you're breaking out.
This is not just sweating either, because yes, the sweating's important, but it's not like, oh, I was sitting here and I just broke out in a sweat, but I'm talking like nothing's happened. That is more typical of your perimenopausal thing. It was like I got flushed and hot and sweaty is quite different. That sweatiness that they're talking about is more a clammy sensation.
Right.
And you don't feel well. You're not like everything's fine and oh, look, I'm sweating. It's I actually don't feel right. And then I've broken out into a kind of cold, clammy sweat. And if you were looking at me, you would have gone, Jodie, honey, you all right?
You don't look like
you
yourself.
You don't look quite right. Are you okay? We're not talking about someone who just broke out in a sweat and looks fine.
Right.
Yeah.
Because not someone who just looks like they've just come out of the gym or out of a
Yeah,
run.
I've got a
Right.
big smile on my face. I
Yeah,
look red
glowing.
as a beetroot, and I'm sweaty because I just
Yes.
ran, as hard as I could for about 7Ks.
Yeah.
But I feel great. It's not that picture.
And then feeling nauseous or vomiting.
Again, they're feeling off. It wasn't, oh, I just vomited out of the blue. They're feeling off, but instead of having some obvious pointer to heart, they've got these other symptoms that are making them think, well, maybe something else is going on, but they don't feel well. And the obvious thing they point to is, I feel sick in the stomach, or I've got this bit of a burning sensation,
Right.
I just don't feel right. I don't feel, that this is I think the important thing is, yes, there's that symptom, but it's in the context of just not feeling right. They may not be able to specify. They might even just say, I just feel off. I don't feel like I've got the energy to do anything. I don't feel right. I don't, they've lost their confidence to just get on with their day. And so they're unable to pinpoint or locate where is all this coming from. And look, even if it is food poisoning, but if you're that unwell, you should get help, because you can't tell what it is that you've got or whether or not you're going to need treatment for it. Something's really not right. You need the professionals to evaluate what is actually wrong. And then get on top of that. And, as I said, like the amount of times that somebody has come in with something and they're sure they've got X, Y, or Z, and it turns out actually it's heart disease. Again, new onset of symptoms that seem, different or abnormal to you should be investigated no matter what you think they are. And then that way the heart stuff doesn't get missed.
I want to talk about women-specific risk factors. What should we know about?
I'm going to divert slightly.
Sure.
So I think, the general trends have been that men have generally been dropping smoking, but for some time women have been picking it up.
Right.
So, and now there's this whole vaping trend, which is
a whole other
conversation. Yes. But from that alone, there's been an uptick in women having more heart disease, and really at a time when there should be a bit less. So I guess that's the first thing I want to say. Women don't think of, I think, that as an important factor as to why they're ending up with heart disease.
How interesting.
Yeah.
Okay. What else should we be thinking about that are gender specific?
Estrogen changes things. Pregnancy changes things. There are very specific things to women that men don't clearly have that affect our cardiovascular risk. Even things like polycystic ovarian syndrome, which doesn't get talked about a lot, can affect younger women. And that those hormonal changes will affect risk. They make you more insulin resistant. They increase your risk of diabetes. They increase your risk of cardiovascular disease long term, increase your risk of high blood pressure. So, there are many female hormone-specific diseases that can affect risk. One that we don't think about, I think, is even arthritis and inflammation. And we now know that, say, rheumatoid arthritis increases cardiovascular risk. I've seen quite a few young women, for example, who have like ulcerative colitis or Crohn's disease. That we now know is associated with increased risk. So there are lots of things that, again, people wouldn't automatically think of as an increased risk for heart disease, but actually do carry an increased risk.
Yeah. And so when we see things like, oh, it's gender specific, it is because of the biologically different makeup that comes with us as women, right?
We are not smaller males.
That's right. We're not just like a smaller 3D print of the male version, right?
Yeah.
So we and that's a really important point to raise, because a lot of the gaps, I think, in the research that's contributed to the knowledge we have to date has been based on a very male dominated research, right?
Yeah, yeah,
And male dominated outcomes, which
yeah.
then lead to male dominated checklists, male
Yes.
dominated standards,
Yes,
male
and then the
dominated
translation of
patterns.
that across to women, like we're the same. And it's only really even been in recent decades where now there are policies that require research institutions, big research institutions, to include women in the studies, and not just a token number of women. They're really trying hard to get a good cross section. I mean, the same could also be said now, not just against of gender, but we're also like, okay, well, if the population studied was Caucasians in a middle socioeconomic
Mm,
climate, that's not generalizable
yeah,
to, say, African American people
yeah.
or Asian women
Yeah.
or whatever it is. But
Or women from different socioeconomic
cultural,
backgrounds.
yes,
Yeah.
socioeconomic
Yeah.
actually matters a lot.
Yeah. Because it affects your diet, it affects your access to
Education,
exercise, it
yep.
affects your education. So this really highlights to me recognizing not just women as a distinct gender in our understanding of healthcare, and awareness and taking in and health practices, but also the intersectionality, right? Because I think a woman who is living in, privileged suburbia, Melbourne, would have a very different life expectancy and healthcare experience, typically, I suppose, in the private sector, as opposed to a woman living out in a remote area who's never really had the opportunity to have, a good secondary or even tertiary education, and not perhaps having the kind of lifestyle that would allow her to have proper exercise or diet, for instance, or access to good quality healthcare. Um, and that's important to acknowledge as well, even
Mm.
as particularly as we are seeking to increase the inclusion of women in research and in science, we need to include that broad range to have that intersectionality in the women that we involve in science and research.
Yeah, yeah, because I think we've learned the hard way that the information we've obtained sometimes is very specific to the group of people studied, and the assumption was that you could just then translate that across the population,
Like
like
a
we're
one size
all
fits
the
all.
same.
Yeah.
But we're learning, especially now with sort of increased recognition of genetics and other factors, that these are not just translatable into the every person in the population. And I think in time we will get much more nuanced care, which means you can't just sort of generalize about someone's risk or and even the risk calculators themselves are becoming more nuanced to try and gauge somebody's risk and optimize their health. And the plan for you might be quite very different to your husband, for example.
Yep. Pregnancy related risk factors. It's something that's affected one of my family members.
Yeah.
So let's talk about gestational diabetes
Mm.
and its link to heart disease for women, because obviously only women would ever experience this,
Yes,
right?
that's true.
But I think for a long time, many people didn't realize that gestational diabetes could maybe 10 years, 15 years, 20 years later come up again as, oh, this is a link to why I'm now having heart disease.
If you have a normal pregnancy, if you have preeclampsia, which is high blood pressure in pregnancy, or diabetes in gestational diabetes, so pregnancy related diabetes, that often can disappear at the end of the hormonal influence. And then it's tempting to think, well, you're all fine now and you might be okay. But what we recognize is that for both of those conditions, you have a much higher incidence of developing blood pressure earlier or diabetes earlier in life. And so it's definitely associated with increased risk. And then those things need to be monitored and tracked in that person until such time where maybe if that disease develops, then it's managed. So just knowing that you had those issues in pregnancy should heighten the awareness for the risk of those things developing in later life. Or if you're my patient, I'll be saying, let's be proactive and not just wait for that to appear.
Yeah.
Let's try and do whatever we can to lower your risk of developing those in the first place. We know you're at higher risk. We can't change that. That's who you are. But what we can change perhaps is when you get that. We might be able to delay that. We might be able to reduce the need for medications if we are proactive about it in the following decades. And I've got women who've come to me with exactly those issues during their pregnancies. I maintain follow-up of those patients throughout the course of their life because we know they're at increased risk.
What about some cancer treatments?
We know there's an increased risk of a number of types of heart disease, with breast cancer in particular, and the treatments that are applied to the breast cancer. Breast cancer cells, at least in a test tube, have also been shown to change the local environment for heart and cause heart failure. So, so it seems that the chemical messengers in breast cancer can be its own risk. But then also the treatments that are applied for women with breast cancer. So radiation therapy to the chest can increase the risk of heart disease, and so can some of the drugs that are used to treat breast cancer. The chemotherapy agents and some of the antibody therapies can potentially cause heart issues, everything from atherosclerosis right through to heart failure, or even Takotsubo has been documented. So I think if you are a woman who's maybe had this in their recent past, but nobody's been talking about, perhaps you've gotten through all of that, which is fantastic. What needs to be followed up is, okay, let's have an assessment of how things are going with your heart, because you're at increased risk of heart disease. Doesn't mean you will have the disease, but there is that heightened risk.
Menopause.
Yeah, everyone's favorite topic.
We can't change the fact that women will at some point go through menopause.
No.
What is the link to heart disease?
Well, we believe it's estrogen related. So again, also, if you've had early or late onset of your periods, that also then affects risk. But if we focused on menopause, the loss of estrogen actually increases the vascular risk, increases the likelihood of high blood pressure. And menopause is an important time for women because they are biologically changing, and the risk of cardiovascular disease, particularly atherosclerosis, the stuff that affects the coronary arteries and causes the angina and the heart attacks, the risk changes as that happens. And that we talk about estrogen as having a protective effect on the heart and the vasculature. And the estrogen that was protecting you when you were younger and making your risk of that type of heart disease less relative to men at the same age is disappearing. And in fact, even in my early days of training, we had a standard list of risk factors that we kind of went through. It was like, what sex are you? What age are you? But for women, it was like, are you premenopausal or are you postmenopausal? Because we knew that postmenopausal women had lost the protective effect of their estrogen that gave them the advantage relative to men of the same age. And we knew that once they lost that they were actually at least as much risk as the men. But I understand there's a lot of people out there that might not actually understand that going through menopause and losing their estrogen actually starts giving them that equivalent risk potentially to men.
Yeah, it may well be that gap in our understanding, really, in not recognizing heart disease as the biggest killer for women. There may well be many women who pre-menopause never really had any issues
Yeah.
with their heart. In
Yeah.
fact, may not have, any significant risk factors, but they're not realizing menopause itself puts them in a
Yes.
category of risk, of increased risk.
Yeah. And you think of all the women out there that have actually had an early menopause, in their 40s, not in their 50s.
Mm.
That's an extra decade of risk. And we're certainly not looking, generally speaking, at 40-plus-year-old women and expecting heart disease and heart risk, but they exist. It is there.
And that when you talk about women who experience early menopause having that extra decade of risk, that's because they've lost that extra decade. For that extra
Of
decade, they've lost
estrogen.
that estrogen.
Yes.
And just so we all understand this, so estrogen is a female-specific hormone
Yeah.
that we tend to lose when we go through menopause because of a fall
Yeah.
in.
So the ovaries, when they're young, they produce eggs, and it's that stimulates the estrogen production and the preparation
Right.
for fertility.
Yep.
Really, once you've lost functioning eggs, you lose your estrogen with it. Broadly speaking, I'm a cardiologist. All disclaimers: I'm not a hormone specialist.
Yep. Yep. Okay. So that's the baseline understanding, at the very least, that all women should understand.
Mm.
So for women who are now starting to experience menopause, they definitely should have heart health on their radar.
Yeah, absolutely.
Okay.
And perimenopause and menopause is a particularly important time in women's health because a lot changes over a long period of time. And there are a lot of symptoms that could also mimic heart disease, such as the sweats, the palpitations, a feeling of panic and anxiety, which, that often women will say, but I don't have anything to be anxious about. But it's like my body is tense and agitated, and I have no reason for that, but that's how I feel. And then there's this, like, it's difficult for other people to understand that that's even possible, and then they feel like, oh, it's just in my head, but it's not in their head. It's actually a biological response to changing hormones. But it's a good opportunity, even if we said yes, because of the perimenopause and menopause, they've developed other risk factors that now increase their risk even further. So it's common for women to gain body fat during that time. And they were doing exactly the same things before when they had the hormones, but now they're gaining weight that's just stubborn, and it's belly fat, and it's in the wrong place, and just no matter what they do, it's not going. That's increasing their risk now of higher blood pressure, diabetes, metabolic poorer health, and all those things are dramatically increasing their risk of heart disease. So it's an important time for them to actually, really make a focus of taking care of themselves. And so that also could be a great trigger for assessing their cardiovascular risk.
And you've also talked about early getting periods earlier or later. So what age are we talking about? I think the baseline age, if I'm not mistaken, is usually about 12, 13.
Yeah, that's
So
the sort of typical age for onset of periods.
right. So
and
if
we know that sort of is a phase-in kind of period.
right.
But for some women, some girls, they experience that several years earlier. Or in some people, and maybe there's other factors like low body weight, athletes will experience it a lot later. And that can be a risk. Not everyone will develop heart disease, and we don't want to scare people. We just want to arm them with the knowledge that they could be at increased risk. Ask the question, get assessed, and then hopefully reassured. But if not, early detection and doing something about it is better than waiting for it to suddenly present in maybe a fatal event.
This other thing that I've become aware of is that many women can have pretty normal angiogram results, but continue to experience ongoing chest pain.
Mm-hmm.
And I've now come to learn that there's this condition called microvascular disease or menarche. What do women need to know?
So menarche is a fairly specific category. It's a term that's been developed to include higher proportion women than men that have what we have by definition is a heart attack. So they have all the features. They have the chest pain. They have the elevated blood enzyme proteins that show they've had heart damage. Could be very tiny amounts picked up in the blood. It doesn't have to be like a lot of, it's not a lot of damage, but it's evidence that there's something's happened in the heart. And maybe they've had ECG changes as well. So they'll present to hospital with that chest pain and feel like, yeah, I feel like I'm having a heart attack, whatever that looks like for them. And they've got these blood results that suggest they actually have had at least this detectable injury to their heart, even though overall the heart functions well.
Right.
And in those, they look like they've got this problem with their arteries. So we're going to do an angiogram in those patients and an echo just to make sure the pump is working normally.
Of course.
But the angiogram, instead of finding a major blockage that's happened, that's caused this heart attack picture, they actually have none or minor narrowings of their arteries that we don't believe have had a role in causing this presentation. And it's where you've got what looks like a heart attack, but not the artery blockages that normally go with it. And it would be tempting to think that, you know, this is not a thing, but it is a thing. There are a number of conditions that can cause that picture, and it is more common in women. So a clot that then dissolves and is settled down, more common in women than men. So this is thrombosis of a coronary vessel.
Mm-hmm.
Takotsubo falls into that category potentially.
Mm-hmm.
We do that. We may capture it or we may miss it. That octopus trap shaped heart. And it recovers fairly quickly. So if you didn't capture it when it happened, it might all look normal by the time you see it.
And again, that's why it was missed.
Yes. Yeah. So that's the Takotsubo. There are a couple of other situations like microvascular disease or coronary vasospasm. So the arteries spasm and cause this prolonged lack of blood flow that causes some injury to the heart, but it's barely visible to the naked eye, but we pick it up on the blood test. And it looks for all intents and purposes like someone was having a heart attack, but then you don't find the blockages. The microvascular disease, this is like, we've got the very big vessels, then we've got the smaller 3 to 4 millimeter vessels that we see when we do the angiogram, but then there's also what's not as easy to picture is that at the end of those blood vessels, there's really tiny vessels that are penetrating that heart muscle and supplying that heart muscle. And for some people, women much more commonly than men, they've actually got disease that's affecting those end arterioles rather than it being like a big clot or a big blockage in one of the more major vessels. And this is problematic because you can't just, you can't see it, at least not with an angiogram.
I wonder if this will help. So I'm going to show you this. It's a really nice illustration that I found on the British Heart Foundation's website. So thank you to British Heart Foundation because it is difficult to understand. Yeah. And I think we previously talked about, the big vessels like the aorta and how we measure.
That one there.
Yeah,
really
that's right. And so when you're talking about the micro stuff, so helpfully the British Heart Foundation, they've sort of magnified or
Yes.
try to magnify. Is that's what we're talking about?
Yeah,
And
the
ordinarily
end
we'd be looking at
vessels.
this, which you can't even see.
No.
So we're really looking at that.
Yep.
Right.
So this is where you'll have the big heart attacks in these blood vessels here.
Mm-hmm.
But this circulation we're not even seeing. It's what's penetrating the heart muscle itself. It's still causing a problem. You can't stent it. You can't bypass it because it's in the tissues. There's nothing to go past if you're thinking of a blockage that you could bypass or stent. And so then you've got to treat it differently. These women are sometimes incapacitated at various points with angina, chest pain or throat, or breathing difficulties on exertion. And this can be somewhat disabling. It will often respond to medication like nitrates. So that nitroglycerin that opens up the vessels, and it's a very quick response, and it eases up that chest tightness and that breathing difficulty, and it can settle it down. So medications such as nitrates might be valuable. But again, this is where we need to look at what are the risk factors, how do we modify those, is the blood pressure controlled, do we have problems with insulin resistance or poor sensitivity to insulin, etc., etc. What are their exercise tolerance like? How do we improve that? How do we rehab them from this so that they're functioning well rather than being disabled by their problem? How do we coordinate medications that help them do that exercise? Because we know they're technically safe in that they don't have a blockage that's going to just kill them, but then they've now got a significant problem, and it affects their lives in very significant ways and increases their risk of other vascular problems down the track. Do you need weight reduction that reduces the impact of stress on the heart? Do you need an exercise program, cardiac rehab? Because even with a sick heart, you can improve the ability of what you can actually do and achieve functionally. And we know that the more people can do, the better the outcome generally. So you might be limited, but that can change. And again, looking at medications that can help with that, the blood vessels themselves.
And what about SCAT?
Yeah.
So that's spontaneous coronary artery dissection. Yes.
Yeah.
Women tend to experience this more than men as well.
This is more common in women than men. It's where there is a problem with the lining and wall of the artery, and there's a spontaneous rupture or dissection. It rips apart. Yes. That rip causes acute blood clot, and it causes this heart attack picture. But there's actually not the standard blockages. They still get treated by opening that back up and stenting it, and it's important to still medically manage that. I've certainly got patients who've had that, and then they've never had another event. We've managed that. We've prevented a recurrence, and they've been fine for years. But it's kind of quite a scary thing for the person who's experiencing it. And again, I think the thing to remember about that is, even if you don't think you have risks, you could still have that.
SCAT.
Yeah. So it's tempting, not to think that you might be at risk for a heart disease because you have none of the standard risks, and then you have something like that where you have this spontaneous dissection. And so, that I guess when it's, the symptoms are happening, the person themselves is thinking, oh, but I can't possibly be having a heart attack, but they are.
Yeah. And that's usually because, let's say, if I've never heard of SCAT, that doesn't correlate. It doesn't because what I know is that, I don't have the, conventional risk factors. On top of that, I don't know about SCAT. So I wouldn't have thought that it was SCAT. So for the benefit of everyone, what are the symptoms of SCAT? Is it's similar to heart attack?
Like having a heart attack. Yes. And it looks like the same, and the same things happen in terms of the presentation and what we find on most of the tests, except when we go have a look with angiogram, the artery is actually dissected. It's it's sheared the wall
Okay.
and split. So that's a bit different because there's not the blockage that we're expecting.
Okay. So this is important, I think, for women to understand. So if I
It's a different
yeah,
mechanism.
it's a different yeah. So if I didn't think or if I didn't have any other risk factors, but I'm now suddenly feeling chest pains or sharp pain and feeling unwell, I still shouldn't rule out heart disease because I should now consider SCAD. That should fall into my realm of consideration, not just let's see how this goes by the end of the day, kind of dismissing it.
Yes.
Yeah.
Well,
All right.
and I think the thing is, like no one wants to waste anybody's time.
Yeah.
But as a rule, I think the ambulance would rather have their time wasted and not
Save a life.
and save a life,
Yeah.
than the opposite of that.
Yeah.
And women are tempted to just dismiss something. But if you're having something that's making you feel fairly unwell, then you should be guided to find out more about what's going on and deal with that, because
Yeah.
it's obviously out of the blue and it's unusual for you and you don't feel very well, and it's better you have that checked out than ignore it, because with anything that restricts the blood flow to the heart muscle, time is actually critical. So once you get beyond about 40 minutes even of having this problem, like if it's gone on longer than 20, 30 minutes, you are now starting to have parts of your heart muscle that actually is dying.
Right.
Because it hasn't had enough blood flow or oxygen.
Right.
So that's why, we have these, in our world, we have to deal with heart attacks as fast as possible, and every minute is important. And our goal is to treat that within an hour of onset. If you've already waited an hour,
Yeah.
we're already losing
Or worst
heart
case,
muscle.
half a day, because some women are sitting thinking, it's not uncommon. Like
no, that's
I
right.
know, and it's not out of any, and this is not in any way a negative sort of criticism or judgment. It is just a very common thing because that's how we grow up. We grow up thinking, let's wait and see. Don't be overly dramatic.
Yeah.
Don't be a drama queen.
Yeah.
Let's just see how, if you
Yeah.
don't feel better. But in a situation of, chest pains,
Yeah.
time is of the
People
essence.
die that way.
Yeah, so that's when you shouldn't be thinking, oh, let's wait and see how I feel, a couple of hours later, because
No.
you're talking about getting treated within the hour.
Yes, that's from time of onset to time you hit the cath lab.
Yeah, right.
That's not very much time.
So from the moment you
60
start
minutes.
feeling those chest pains, you're on the clock.
Yes.
And it's a race to get to the hospital and a race to get that
don't
treated
drive
ASAP.
yourself. Get an ambulance to
That's
take
right.
you.
Do not drive yourself. That's right.
If an ambulance
Yeah.
comes and they go, no, everything's fine, you're fine, and they say
Then
you don't
good.
need, that's great. And they won't consider that a waste of time.
Yeah. That's good. Then you can take yourself out and have a nice dinner
Yeah.
on the day, but don't mess around with
Yeah.
not calling. Right. Okay. Another big one that I've learned along the way is this specific type of heart failure that affects women particularly. It's HFpEF. So that's heart failure with preserved ejection fraction. What does that mean?
So this is a situation where there's, again, insufficient power of the heart to get blood flow around to all the organs effectively. You get back pressure, which builds fluid that seeps out into the tissues, into the lungs, into the legs, into the wherever. And this causes breathlessness and fatigue primarily. It can cause swelling or weight gain, and it's quite a debilitating condition. It is more common in women than men. It is more common as we age. And again, it's often it's a high likelihood that it presents with other risk factors. So this also makes it a worse condition for people to have, but it will go hand in hand with people who have a higher risk of blood pressure over their lifetime, being overweight, postmenopausally, of course. It doesn't tend to happen so much in premenopausal women, but definitely escalates postmenopause. It is, again, more associated with that sort of metabolic syndrome, blood pressure, diabetes, overweight. Sleep apnea can be another thing to consider in there. Women don't think of themselves as snorers, I think, in general. I
And
think
it's not the cute thing. It's not the
no, none of
sexy
us want to
thing. And so
admit
no
it.
one, yeah, that's right.
But actually, if you are a snorer, then you
Mm.
need that investigated, because that snoring, and especially when you stop breathing in between the snoring, is a concern, because at that point you're not getting any oxygen to your brain, let alone anywhere else.
Right.
Momentarily, of course.
Yes. But if it happens often
But that's
enough,
happening a lot
Yeah.
overnight, and you're not even aware of it. You're probably only aware if your partner or husband or whatever says, no, you snore and you stop breathing, and
Yeah.
that happens a lot.
Yeah.
Then that needs to be treated,
Yeah.
because that's a risk factor for these things.
Yeah. Because we're not talking about a one-off loss of oxygen of a couple of seconds. If you're a chronic snorer, like with sleep apnea, we are looking at a lifetime of accumulated loss of oxygen, and therefore a lifetime of accumulated damage to your heart and other parts of your body, presumably.
Yeah.
Right.
And this is where all the silent killers apply, particularly like the blood pressure, the insulin resistance. Those are the things that are in the background that, unless you're actually looking for them, you may not know. You might not know you have it. And so you've got to actually test and monitor for these things to see if you have them, and if you have them, manage them. And if you do that early enough, again, because these things creep up on us and it's not an overnight, oh, I just got, blood pressure and now I'm having a heart attack. These things are accumulating, as you said, and then the number of risks are accumulating as we get older, because we're getting older. There's all these other things. So again, you think, oh, I'm a female, it's only age I need to worry about. No,
it comes with a whole package of things.
Yeah.
Right.
Yeah.
Right. It's really interesting, the focus now on women's health. It's actually taken us a little over 2,000 years to start to be heard as an entire species, right? As the female species. It's taken us over 2,000 years for us to start talking about menopause, for us to start talking about women and mental health, perimenopause, and for us to now start talking about women's heart health, and to recognize it as the biggest killer for women, more than all cancers combined, right? It's great to see more female scientists, more female cardiologists, and also great to see lots of movements now among and within women who want to advocate for ourselves. Like, I want to know how to advocate for myself now, right? So not just being part of, not just wanting to, let's say, complain, but also wanting to do something positive about it. I want to be part of this. It starts with me, right? So if I want to learn how to advocate for myself, I want to know what to ask when I'm at the doctor's. What are some of the things I can do?
Well, I think just show up first and say what you're there for, what your interest is.
Yep. So one, schedule the appointment and show up. Right.
Yeah, because I think that's the great opportunity. I do this. When I go to the GP, I'm like, right, I'm here. This is probably the only time you're seeing me this year. So hit me with whatever you think is important for me to deal with, and I will deal with it.
Yeah.
I think, first of all, just say, okay, well, it's better to be preventative than to try and cure something after the effect. And given we know that cardiovascular disease is the number one killer in women, we're not talking about something that's obscure and rare, and we're not going and with a view of, I want this, test that affects 1 in 20,000 people, and just because I'm worried I might have it. We're actually doing something that's really, really common. And 1 in 3 women die of heart disease, not something else. So in that instance, I think, what's a good idea is for someone to say, well, right, I want to be proactive. Amber, go off to see your GP as first protocol and say, look, I'm aware that, I may actually be having increased risk of cardiac diseases now because of whatever they are. You know, I'm aware of a family history, or I'm
Mm.
starting to get older.
Mm.
I'm not sure of the other things, but I'd like you to put me on the right path to have these things checked out and assessed, because I would rather be forewarned and forearmed than wait till 20 years down the track when I'm having my final event. And so I have quite a lot of patients who now just come to me. They say, I'm fit, I'm well, I think I'm fine, but I need you to actually have a look and see, am I really as fine as I think I am? What, you know, I'm now in your hands. What would you do test-wise or whatever to reassure me that I'm on the right track? And I really appreciate when someone actually wants to take that. I'd much rather see someone who's healthy and well, who wants to now be proactive about their life and keep them that way. And, you know, things evolve quickly. So even in the last 5 years, the way I do that and the advice I'm giving is changing quite rapidly. So, you know, you might think you did all of that 5 years ago, but now there's tests we're doing that I wasn't doing 5 years ago.
Wow.
So, and they have an impact, a significant impact on risk. So that's where you know, a lot of my patients will elect just to come for an annual review like they would for their GP, because I have different information for them and a different point of view on how I'm approaching their prevention and their risk. I have maybe, you know, there's new research to share or whatever it is, but they can now be very proactive rather than wait till it all falls in a heap. And in the event that something does happen, they're already set up with those supports and links. And, you know, it's not like, oh, I never thought about this. But hopefully they never need that, because we're already on a path of prevention. And we know if we modify those risk factors early enough, we've got time to change that trajectory of risk. So I would just ask that everybody, especially women who have any family history, women who've had cancer, or women that know that they've got at least one risk factor, have that conversation with their GP. Consider, and it's not for everyone, not everyone will want it, but consider going and seeing a heart specialist, even if it's a one-off, to say, I now understand what my baseline is and what I've got to look out for, what I've got to work on. Have that conversation, have the tests, and then they know, what's my plan for the future? How often should I come back and see you? What are my warning signs that I need to look out for, that I need to really come back and see you?
Yeah. So just to take it a step back, right? So when you say if they want to go and see a heart specialist, so in order to do that, the first point would be to go to the GP,
Yeah, they need a
have that
referral.
conversation, and then actually ask for the referral, right? Because I think that's where some of us might get a bit stuck.
Yeah.
You go to a GP, so self-advocacy is a spectrum,
Yeah.
right? There is self-advocacy in a preventative way when
Yeah.
you are feeling fine, but you want to be proactive.
Yeah.
There is still self-advocacy there because you schedule maybe once a year, twice a year, see your GP, you do the usual standard blood test, pressure and everything, the annual physical it used to be called. And you might still be, you're still clear, which is great, but you can still advocate for yourself by actually asking for that referral.
Yeah.
Because I think many people might then not realize they need to ask for that referral to get to see a specialist of any sort.
Yeah. And look, sometimes the GPs will say, oh, you don't need to. That's okay. They're entitled to their opinion.
Yeah.
But if you really want that proactive approach, I'd say, just say to your GP, well, I appreciate that you don't think that I need to go, but I would really like to.
And that's why it's called self-advocacy,
Yes.
isn't it? And that's the importance of it.
Yeah.
And we're not sort of saying, oh, the GP should have put you or should not have put you. But if we're simply just reframing this as really taking charge of your own health, your own heart health, self-advocacy being an important component of that, then it is precisely when there is a little bit of pushback, that self-advocacy steps in,
Yeah.
that you then need to say, no, I'd really like to,
Yeah.
just so that I'm on the front foot.
And
Because I've got, family members who've had this, even
yeah.
though I'm fit and
Yeah.
healthy. All right, so that's
And this is where we have choice, right, Amber?
Yes, exactly.
Like that we are lucky we live in a society where we can choose for ourselves. And that's one of the great things is, GP might say, you should go see a cardiologist. You might say, I don't want to. That's your choice.
Goes both ways.
But, equally, don't be easily dismissed if it's what you really want.
Yeah.
As I said, some people, prevention is what they want. They want to be forearmed. They want to go for it and give themselves the best chances of everything. And other people are like happy to stick their head in the sand. I don't recommend that, people, but yeah, you've got power to advocate for yourself. You've got power to have the choice, because it is your prerogative to go and get assessed if that's what you want. But then it forearms you, and it might only be so that you get assessed and you are reassured that you perhaps don't have the same disease that your family history has. But isn't that good to know that, and that you don't have to have unnecessary medication, for example? Sometimes people are just put on medication because there's a history in the family, but then they don't have the disease.
Right. So that's also something we don't want,
away.
because we don't want that kind of pharmacological toxicity.
Yeah.
Yeah. Then there is the other spectrum as well, the other end towards where we move towards higher up the spectrum of self-advocacy, where if you feel symptoms, even if you might think it's nothing or it's vague, don't think that. I think we all need to rewire our brains to not resort to, oh, it's probably nothing. That's often our default.
That's our default.
Now, I've got to admit, sometimes it's my default as well.
I've had that too.
Right? And thankfully, so far it's been good, but with other things. But I think we do really need to rewire ourselves, me included, to switch our default to, oh, I feel something. I wonder what that is. Oh, maybe I should schedule an appointment to see the GP. I should write this down. I should journal this. I should remember when this happened. I just make a note on my calendar. And if you're dismissed, keep pushing, keep going, and maybe if you have to switch doctors, right? If you feel like you're not being heard and if you're being dismissed, it's okay to switch GPs or switch specialists.
Or get a second opinion. If the second opinion says, no, you have nothing to worry about, then maybe you have nothing to worry about.
Yeah.
But if your gut is telling you otherwise and your first opinion is dismissive, go for a second opinion and just make sure. And then, if you get that same answer, at least there's consistency and okay, it's probably all right. Yeah. But, what if the second opinion actually picks up on something that the first person wasn't aware of in that conversation that leads them down the path to investigate, and something is there?
And we know that there are countless examples of this, actually, whether it's heart disease or any other kind of thing, for instance. Yeah.
And, it's go to someone that you do feel that you are being heard and understood and not dismissed, because I think that's very important. That relationship that you have with your healthcare provider really should be one where it is it's a consultation, right? There's communication and there's understanding between those two individuals as to what you're trying to achieve, what you're trying to look at, and what outcomes you want. And that is consultative.
Yes. I love that you've emphasized that consultation does require that it's a two-way traffic communication, that you need to be heard, you need to explain. And if you find it difficult, write it down. Just use whatever words that you can, and then remember it, bring it with you. So I think that's another important reframing that we need to understand. The appointment is a consultation. I really appreciate that emphasis on listening, and thank you very much. If there is one thing you'd like our listeners or our viewers to take away from this, women in particular, this being Women's Health Week, what would it be?
I think it's really important for women to think of themselves equally as having the potential for heart disease as any other person, and not from a place of oh, this won't happen to me.
Mm.
Because we know statistically that it does. And it's likely, it's not unlikely, it's likely that heart disease affects most women. So, in one form or another. And the more, again, we don't have to be fear-mongering about this, but just to say that because it is as likely as us getting older that we would end up with some kind of heart issue or heart risk factors, if not the heart disease, we should be proactive at least to assess the risks for the heart disease. And in that process, some people are going to find they have heart disease. Other people are going to be given the all clear, but told, these are the things that you want to watch for in the future. And I would like you to consider reevaluating those in the next few years and take that proactive approach around our health so that we can change those awful statistics that suggest that we should die from heart disease and that it's much more likely that we'll die of that than we will die of cancer. So that is what I would like women to take away, is that, yes, this is something that should be a high priority. The risk factors at the very least, even if I don't intrinsically think of myself as going to end up with heart disease. But the reality is that many of us will. And earlier than we think. And the earlier we're aware of it, the earlier we can do something to change the likelihood that we get disabled by it or die from it. And women, we need to stop thinking about always caring for everybody else because we're primed to think that way. We have to think, okay, if I want to be that carer for everybody else, how do I look after myself well enough that I'm in a position to continue to look after all those people? It starts by looking after yourself. It starts by having those things assessed by a professional and getting a good picture of your overall risk, what that looks like for you in your context of your family history and your genes, and what your arteries do or don't look like if that's a step you want to take. What are all the other factors irrespective of what your arteries look like, and what can I change? As a woman, you've got a lot of opportunity to change your cardiovascular risk because there are things that we can do something about, and we can be very proactive.
Can I add one point to that? Because I'm very mindful of, and it happens to me, I think like this as well, about not wanting to waste anyone's time. Not scheduling that appointment because I don't want to look silly. I don't want to be a burden to the doctor or to the healthcare system. But the more I think about it and looking into preventative methods and looking into better management methods and having looked at, the costs of hospitalization, here's a reframe. By being proactive, if we take preventative steps, if we practice self-advocacy, if we schedule the more regular GP appointments, start seeing specialists earlier on, we are actually reducing the overall burden potentially on the healthcare system, because potentially we're taking ourselves out of the hospital system by not ending up being the sudden out of the blue heart attack. We're removing ourselves from the scale of burden when it comes to the cost of expensive medication. We're removing ourselves from the burden of specialist care, of expensive equipment, because we've started early. And so we're able to then take some of the free sort of lifestyle management measures. And therefore, does this make sense at all?
No,
and
absolutely.
Therefore, we're actually, in a way, we're playing our part in reducing the burden to the healthcare system.
Critically.
So I hope that's a reframe.
No, I actually think that's the very best way to look at it, is we're not being a burden by fronting up at this early point. We're actually reducing the burden on society as a whole, on taxpayers, on the carers, on everything that extends from, somebody who ends up with major heart disease, and the resources that go into that are substantial. If you never end up on that path because you've taken measures earlier, you save the community thousands and thousands and
Millions,
thousands
I
of
hear.
dollars. Well, yeah, collectively it is
Yes.
multi-millions of
Yes.
dollars.
Yeah.
Multi. So well worth the effort early on.
So self-efficacy, listen to yourself
Yeah,
and take care of yourself
Yeah.
so that you can take care of others.
absolutely.
Thank you, Jodie Ann.
You're welcome, Amber.